No, I've talked a lot about cone beam CT interpretation, and a lot of this is just intro stuff to kind of introduce to you technology of cone beam CT and how it works. Has anybody been exposed to cone beam CT? Been able to look at the software, look through scans at all? Not many, a couple of you. Those of you that have, what's the point of cone beam CT? Why do so many dentists use it now? And more are using it every day. Yeah, that's kind of the big driver, probably the number one driver, implant planning, right? Always good to be able to see 3D view of the bone when you can. I have done some expert legal consulting, and it's out there where if something goes wrong with an implant, the question's going to come up. Why didn't you use 3D planning? If you didn't, why didn't you use 3D imaging? And then most of them will say, well, it's available. We didn't really see it was needed in this case. And so I would say by default, it's a good idea. And that's what we do here. Whenever there's an implant, they do a cone beam, right? If you remember the doses are not that high. Then specifically with the machine I said over here, it's even lower than that average 100 microsievert that I gave you for kind of your average cone beam CT dose. And so the dose trade-off, I think, is relatively low for the benefit. I already showed you, well, I showed you part of this image where we tried to find where the school was. This is Utah Lake. Me and my wife up on Timp. And so we'll talk about what, why, and how. So what it is, why we use it, and how it works. I'll start with what. So comparisons with other technologies and a little bit more depth about dose. So mostly we've been talking just about 2D imaging. So here's our panel. As we know, it's 3D image, but it's kind of stretched out to one flat rectangular image. As far as image formation, they're both done the same way. So it's just shooting x-rays through the patient. So that's why it responds the same way. Light areas in a two-dimensional radiograph are going to appear light in a three-dimensional. This is a 3D reconstruct, so it changes some of the color to orange and yellow. But if you're actually looking through the image data itself, it's still just gray values. So just anywhere from light to dark. And radiopaque structures are going to appear, let's jump down to the bottom here. Instead of using the terms radiolucent, radiopaque, we just call it hypodense and hyperdense, but it's the same concept. So areas that are denser than others, it's going to block out more of the X-ray, it's going to attenuate more of the X-ray beam, and it's going to appear more hyperdense. I would say the weaknesses, which is being overcome in 3D, is shadows, overlap, image distortion, as we know with panoramic. But the weakness and what I call the Achilles heel of CBCT is artifacts, particularly dense object artifacts, especially metal. So people that have a lot of metal in their mouth, there's going to be the streaking light and dark lines that extend in the axial plane. You can see that to some degree. This is my head, actually. I have a lot of metal crowns, metal restorations. And you get these streaking artifacts that go in all dimensions in the axial plane from those artifacts. It makes it really difficult or impossible to diagnose caries, but these imaging modalities are very complementary. That's what I like about it, right? The benefits of 3D imaging is some of the weaknesses of 2D imaging. And then vice versa with 2D imaging, especially with intraoral bite wing radiography, we see a really good view of the crowns, and that's how we diagnose caries. So I always talk about these imaging modalities as being complementary. Strength of 2D imaging, inexpensive, relatively lower dose. Strength of 3D is that accurate spatial resolution. Also the ability to measure spatially, so accurate spatial measurements. And fairly good resolution, but obviously not as high as your intraoral imaging. Abilities to see within or beyond structures. So we'll see, you can look through different planes to see through structures. What I really should have done is should have brought my laptop so you could see it actually in practice in the software. So maybe we can do that a little later if you want, or in a later date. Oh, here's our 2D and 3D Mario. So I might have got a little carried away with all these images showing how there are limitations with 2D imaging. This goes for radiography as well as just photography. Certain things tend to overlap each other. And if you're not sure what you're looking at, things can look very strange. Here's a dog eating some people on the beach. That one's interesting. Then I like this one. Go America. And so obviously we limit that overlap of structures. Eliminating ghost images specifically talking about comparing to panoramic imaging and being able to measure accurately between structures. That's a benefit of cone beam CT. Disadvantage, higher dose. Again, I put that with a question mark. If you look at some of the doses on some of these machines, it can be as low as a pano. It is a higher cost machine. And then artifacts I've already said. Similar to pano, I would say resolution. When we talk about resolution, it's kind of on the same order as panoramic radiography. Talk a little bit about geometry. So it gets its name because of this cone-shaped beam, right? You have an X-ray source, it goes out in a cone, really similar to 2D projection geometry. This is basically like a lateral cephalometric projection, but it takes several hundred projections as it goes around the patient. Each one of these would be a really low dose projection, but the initial raw data image is just cephalometric projections around the patient, usually in a 360-degree arc, although you can do it in just a 180-degree arc, but that's going to create more image artifact. And then compare that with medical CT or multi-slice detector CT. Originally, multi-slice detector CT started out just doing one single axial slice per rotation. Nowadays, they have rows of detectors, where it's 64 or 128 rows of detectors, and it goes in a spiral motion. So it just continues imaging as it goes up the plane of the patient. And so that's considered fan shape geometry as opposed to cone beam geometry. And this kind of shows the difference of that. Think of this as similar to collimating a beam and eliminating scattered photons reaching the sensor. If you have a cone-shaped beam, you're exposing all the head at once. That leads to a lot of these scattered photons. Remember a Compton scatter, it scatters off in different directions. A lot of those will go forward, and that can interfere with the image. You get a lot of noise in that image. But with a fan-shaped beam, and just taking one single slice at a time, most of those scattered photons scatter off in a different direction, and they don't interfere with the image. And so that is advantageous over cone beam. I would say it takes longer, but with these medical CTs, they spin so fast, it's still just a matter of seconds with a medical CT before it's done. And so that's one advantage of medical CT, and that's one reason that they have better soft tissue contrast. When we're talking about seeing contrast in low contrasting structures, noise plays a big part of that. But I would say another thing, if you just look at the sheer MAS, just look at the MA of a medical CT, and it's a lot higher than your cone beam CT. And so they're just exposing the patient to a lot greater dose. And that's another big reason why there's better soft tissue contrast on a medical CT. So this is side-by-side comparison. Trying to bring out the soft tissue contrast in a medical CT, you can really see these fat planes between the muscles. Even the tongue, the different musculature in the tongue, it looks like it has different shades. And you can imagine salivary glands, we don't see it here, here's the masseter. But salivary glands are gonna show up as a different density than muscle in a medical CT. But in cone beam CT, mostly the soft tissue looks the same. Yeah, you can see fat planes, and you can see lymph nodes because these fat planes stand out quite a bit. You see the platysma. To some degree, you can see in the intrinsic musculature of the tongue, but it's just a lot lower contrast resolution. So if we're looking at soft tissue, medical CT is better. When I talk a little bit later about MRI, MRI is the standard, kind of the gold standard for looking at soft tissue contrast. But CBCT is really good at looking at hard tissue contrast, which for dentists, that's mostly what we're concerned about. In our radiographs, that's mostly what we're looking at, right? And when we're implant planning, you really want to see where that bone is. And so we have as good or better in some cases of spatial resolution compared to medical CT. And so for purposes as dentists, and actually ENTs are starting to adopt more cone beam CTs. It shows really good spatial representation of the inner ear ossicles, all the different inner ear structures that they may be looking at. The sinuses, of course. And so there are other medical professionals starting to adopt CBCT, lower dose, lower exposure to the patient. Not as great as soft tissue contrast, but if that's not your primary concern, then CBCT is a great option. So let's compare now to medical CT or multi-slice detector CT. It is reduced size and cost, right? That was opposite comparing to pano, obviously. One thing we have is the ability to collimate the X-ray beam. We can choose a really small field of view. If you're just taking a single implant, you can just get one arch at a time. And just like we talked about with collimating an X-ray beam, collimating the size is going to create a better image because you have less scattered photons reaching the sensor, so less noise. Relatively good spatial resolution, relatively low dose. I consider it about 10 times less dose than a comparable head CT. Largely that's because of the 10 times lower MA. You have interactive analysis. One of the great things in our software, in our images in cone beam CT, is if I want to change the orientation, I can. It's not quite as technique sensitive to patient positioning. As long as the patient holds still, that's the major thing. But if their head is off a little bit in a pano, it's going to look wrong. Like you guys know how to recognize panoramic imaging errors by now. But in CBCT, you can just reorient the whole thing. And in our software, you can do that on the fly. If I want views of the TMJs, there's some ideal views where you slice it right down from pole to pole, and that's usually not a perfectly sagittal slice, but a little bit more anterior toward the medial. And you can just choose that and do that on our software. They can't do that in most medical CT softwares. If they want to reposition something, they have to send it back to the acquisition computer, and so one of their radiology techs has to do it for them. And so when they prescribe something, they have to be very specific. If they wanted a TMJ view, they need to tell the technician, we want this TMJ view, or whatever certain view they want to see. And so that's a huge benefit of CBCT software. Disadvantage of cone beam CT is we talked about image noise. Part of that is because of the large projections it's taking with that cone beam geometry. And then part of it is just strictly the difference in MA, the difference in dose to the patient. That's what leads to poor soft tissue contrast because of Compton, other scatter, lower exposure. And then there are inherent limitations of a FPD sensor. Remember we talked about flat panel sensor detector. It's similar to intraoral, but it's amorphous silicon, and so not quite as highly detailed. It also has a nonlinear response to radiation. And so there's a lot of software, a lot of stuff that came out that would let you measure the density of bone when you're planning an implant. And that's supposed to give you an idea of if it's dense enough that implant is going to osteointegrate. But what they found is, since it's nonlinear contrast, those gray level values are not very reliable. And so I think to some degree you can kind of look at the pattern of bone, and it may provide some help. I mean, overall, though, you can tell if a patient is osteoporotic. They've been doing this forever, since before CBCT. They look for those signs of osteoporosis in the pano. And if they have that thin inferior border, if the external oblique ridge, that was one I haven't taught you guys yet, maybe I mentioned it. If that really stands out and they have marrow space that just looks really low density, they're probably fairly osteoporotic, and that's a risk factor for osteointegration of implants. All right, so what was the dose I told you to remember for cone beam CT? Just on average, because there's a huge range. What's that number? 100. Yeah, 100 microsieverts, just kind of an average dose. The dose charts we used, I said, some of those higher end ones, they were looking at older machines that had a lot of wasted dose. It was exposing the patient consistently, but it wasn't measuring the image consistently. So you had a lot of wasted exposure, and that was as high as a medical head CT at about 1,000 microsieverts or more. And so, yeah, most of them have come down quite a bit. So 100 microsieverts, if you assume kind of an average for a large or medium volume CBCT, what's that compared to with intraoral? Intraoral is 5, so about 20 intraoral radiographs. Of course, we could talk about the low dose settings on our machine here, and we can actually get a medium field of view, and it's still 20 or fewer microsieverts. So it's still comparable to just 2 or 3 intraoral radiographs. And so that's why I think the trade-off for implant planning, I think it's kind of a no-brainer. With that low a dose, and you can see the bone where you need to, you're not going to see super high detail of structures. But for measuring bone for implants, you don't necessarily need sub-millimeter resolution. All right, so I sit here and I talk to you about how low the dose is. Of course, we always want to follow the ALARA principle. So we're limiting dose as much as possible. And then these are numbers you already know, right? 3.1 millisievert, that's what our annual effective dose in the US. So your average exposure to just background radiation. And then it's the same number for additional exposure due to medical and consumer products. Relatively low public impact by the dental community. So on average per person throughout the US, they only receive about 7 microsieverts from dental diagnostic radiation. All right, anything new here? This is one I told you to remember. Some are as low as 10 microsieverts or now even lower. 10 times higher on average for a multi-slice detector. 1 day of natural background radiation, remember that one? Or I made a little infographic here, not sure how helpful it is, but putting everything in the comparison of natural background radiation and FMX is about 10 days. You can do a small field of view for only about 20 microsieverts. So just a couple of days background radiation. Large field of view with high settings. This is probably the largest we could get with one of our more modern machines, is about 200 microsieverts. Compare that to the daily background dose of a medical CT, specifically a head CT, because as I mentioned, I think just yesterday, the abdominal CTs, other types of CTs can be a lot more. But this, I think, is getting more significant when you're around the order of hundreds, over 100 days, natural background radiation. And remember these other things you can compare to? I know we've gone over that, so I'll just kind of skip through. Or you could compare one cone beam CT. If it's 80 microsieverts, that's equal to about 2 cross-country flights, 10 days natural background radiation, or eating 100 bananas. You like the banana equivalent dose? That was one of my favorites. Well, let's go into why, and which already came up. Kind of the primary driver is implant planning, right? You can use the software. You can actually plan a guide. Have any of you guys done that? You can plan a guide that the idea is it directs the drill right into where the implant goes. And now they have, you guys probably weren't here, but I think it was last year they had someone that was coming and just kind of showing us how a robot works. They have these surgical robots. And you do the implant planning in the software. You choose the direction it needs to go in the bone. You choose the depth. And the robot actually directs your hand to place it just in that right plane. Of course, you have to have the patient with a splint on, with a guide on. You have to have radiographic markers, and it will direct you right into that space. I think we don't trust robots to do it alone, so you still have the dentist's hands on it, but it's really cool. Like you have that tactical sensation, and it's kind of limiting where you can go in relation to the patient. So a lot of neat technologies out there to really accurately place and plan implants. So yeah, that's the number one driver. And like I said, most legal cases I've seen regarding cone beam CT and radiology, it's around implants, because that's a big thing out there right now. But of course, there is the possibility of misdiagnosis. Actually, a while ago, that was the number one reason for lawsuits against dentists, was misdiagnosis. And so I don't know if that's changed, but it just seems like implants being more and more popular, those are the cases that are out there. Because anything goes wrong with the implant, what do they want to do? They're going to want to blame the dentist. All right, here's a case where we have a panoramic reformat. And just based on this, looks like the implants are within bone. This one has some strange angulation. Maybe it just looks like a smaller implant, but it looks like there's plenty of bone around them. The nerve canal goes way down here. Harder to see here, but the nerve canal is way down there. And so it doesn't look like it's in the nerve canal. It looks like it's likely within bone, but you look at the cross-sectional area, and this one's not too bad, actually. But look at the angulation of the implant. Maybe they needed to do that for the restoration planning. But they almost went out and they perforated that lingual cortex just a little bit. Probably not enough to be dangerous, but you do have the lingual artery in there. And there are cases of dentists perforating into lingual or other arteries and potentially causing death. So do be aware of these. Because we don't know what this bone looks like in cross-sectional image unless we have the 3D. And now we see in 3D, what's that structure right there? That's one of your anatomical structures. It usually shows up as just a big radiolucent area in the posterior mandible. That's your submandibular fossa. And so this one was okay. They just kind of went into that cortex. Maybe they perforated a little bit. But there are cases like this, where in the panoramic view, it can look like everything's fine. It's within the bone. But looking at the angle of the implant placement, they really went out the lingual cortex here. And so this was a case of one of my classmates. He brought it to me. He's like, I'm getting pseudo of these implants, and it's ridiculous, you know? And he shows me this pano. First of all, you see a pano this poor quality, usually it's from a legal case. They just print off things, and what I mentioned about printers. You really can't see much with the print quality, but he's like, yeah, look at that. Those implants look like they're in a thin bone. You know, I took pano, that looked great, but she went to some oral surgeon because they were bothering her, and he took a 3D view, and here's his implants that he placed. He's like, that's not so bad, is it? And what do you think I told him? Well, this is the worst I've seen. Looks like you were trying to cross the T rather than go into the bone. He's like, yeah, well, I've learned a lot since. I do a lot better now. So hopefully that's true. But his argument was these are osteointegrated. They're solid in there. Even a little bit of bone. You know, the titanium really, you know, if done or if the body heals well, titanium really integrates into bone. And so these could be solid in there, but she's got these things kind of protruding out of the back of her, the lingual surface of the mandible. And so the surgeon saw that, and I don't know if the surgeon encouraged her to sue him, but he was under some legal litigation. This case looks great, right? Right in the middle of the teeth, plenty of bone around it. But this one's buccal to the bone. So this is what we call soft tissue integrated, where it's just sitting in soft tissue. I mean, it may have been some of the threads of the implant just barely integrated into the bone here. And so just a few cases. This was another case I was involved in. Not great quality, but these are maxillary implants. And the bone of the sinus goes about like this. They plan these implants just based on panoramic imaging. And they misinterpreted the depth of bone because this patient had so much fluid in the sinuses. They had some sclerosis. This patient had a long history of sinusitis. And so they asked me to look at this. And at first I'm like, how can I defend these guys? You know, they put 8mm implants in 3mm of bone because based on their initial pano, they'd misinterpreted it. They thought that was all bone through there. But then, you know, I'm thinking about it and looking through their whole history. This patient had a long history of sinusitis and problems before they ever placed the implant. If you read any implant book, recommends not placing implants in the case of sinusitis until, you know, that gets taken care of. You know, consult with an ENT, get that under control. And so, yeah, they sunk these implants well into the sinuses. And this patient continued, I should say, to have sinus problems. They saw the ENT, and the ENT sees these implants, and where do they point the finger? Like, well, these implants are causing the problem. I will say I've seen probably hundreds of implants at this point going into the sinus, with most of them not causing problems. That doesn't mean it's a good idea, but I think that's a point that you should take. You know, the body, for the most part, responds well and heals, but don't plan on placing implants into the sinus. That's why we do sinus lifts, right? If you haven't heard of sinus lifts, that's where they push the membrane up. So surgically, you drill into the bone. There are different ways to do it. The least invasive way is just to go through the implant hole. You can drill a hole into the implant and gently push the sinus membrane up and then pack bone in the floor of the implant. Or they used to go from the side a lot more. But yeah, the point is pack bone in there, let that bone heal. Probably the most ideal way to do it. It takes several months for for bone graft to heal and kind of integrate with the rest of the bone. But then you have solid bone in which to place implants, and the more stability you can get, they call that the initial stability of an implant, the more likely that is to integrate and be successful. And so, yeah, that was a bad case. See very sclerotic sinus borders. And see all this metal implant, even around or metal artifact, even around the implants, there's artifact. And so I mentioned the Achilles heel of CBCT being artifacts. If you ever have two implants right next to each other, both of them next to each other, you get what's called the beam hardening artifact, and it just basically makes that whole area hypodense. So it's really tough to see bone in between implants. But in this case, we had the pano as well. We could compare it, and there was just not a lot of bone there. All right, you can also trace the nerve with software to make sure you're avoiding the nerve. Sometimes the inferior alveolar canal is difficult to see. In a patient that's somewhat osteoporotic, it's really tough to see those borders, and you may lose the borders of the canal. And that's where I like to look back more distally, where I can see the nerve, and I start tracing it anteriorly. And maybe more anterior toward the mental foramen, you can see the nerve canal again. And then you kind of connect the dots, because nerves are not known to really change direction like that, up or down. And so you can get a fairly high accuracy, likelihood, I would say, of where that canal is, even if you don't necessarily see it right in the area of the implant. And so all these things are important with implant planning, because obviously you want to avoid the canal, right? There's neural, but there's also vascular structures in there. It could cause damage to the nerve, cause pain and paresthesia of the mental nerve. Not a good thing for the patient. All right, another one showing once we've traced this nerve with cross-sectional images, we see that it's gone more than halfway through the canal here. And so this was causing the patient's symptoms. Not a good scenario. All right, let's talk a little bit about endodontics. I would say most endodontics now use CBCT, and usually they'll have a small volume where they can really limit that volume to just a few teeth, and they can get as high of a resolution possible from a CBCT. So there's different types of cone beam CTs out there, and depending on your use. Most general dentists, you might want something that does a fairly large field of view. So the one we have here on the first floor, it's an iCat. It does a medium field of view. Their newer machine, their biggest advancement is lowering dose. And so that's great for implant planning for most cases. But that machine, I would say, is not the best for endodontics. If you're looking for a fracture in a tooth, in most cases, you're not going to see a fracture, even if there is one. We'll talk a little bit later about resolution, but the highest resolution we've been getting from CBCT is really about 0.3 millimeters, which is in most cases not high enough resolution to see a fracture. Intraoral radiography, you can see fractures, but it has to happen to line up perfectly with the X-ray beam. And so it's going to miss it in most cases. So when we're looking for tooth fracture, mostly what I'm looking for is signs of fracture by bone loss around the root. And have you guys been taught that J-shaped radiolucency, J-shaped periapical radiolucency? If you have that, and so you have the lucency of the apex, but then also creeping up a side, either in intraoral radiography, you can only see it on the mesial or distal surface of the root. That's one of your key indications of a potential root fracture. And I'm looking for similar things in cone beam CT, but now I can see buccal and lingually. I can see into the furcation. And so if I see this lucency just kind of cupping around the root of a tooth like that, that's more of an indication of fracture. But there are cases where you can see the actual fracture line. There just has to be a little bit more separation between the pieces of the root that are fractured. But it is great for looking at the anatomy of the canals. That's why most endodontists at least have access to it. Endodontists get the difficult cases, right? These teeth with 4 canals, 5 canals maybe, and they're winding in different directions. Maybe a lot of pulp stones that they've got to drill through. And so it's a huge advantage to them to be able to see that before they go into the tooth and be able to plan and expect what they're seeing. All right, here's a case. This patient had some pain on tooth. They weren't sure where it was, but somewhere up here in the upper left. They did some percussion. It was more sensitive on 13. They took a radiograph, and it wasn't super descriptive of what's going on. They expected, maybe a periapical radiolucency. You see maybe potentially some PDL space widening here, but it wasn't, it didn't correlate specifically with the amount of symptoms that this patient had. And as I talk about indications, that's one of the indications for CBCT. Most of the guidelines say you don't use it by default, just like for any radiographic prescription. But when the symptoms don't match what you expect to see in your radiographs, and you think there's a good chance that you'll see more that helps you diagnose with 3D imaging. And so that was the case here. What they're seeing here didn't really match the patient's symptoms. I don't know if they got variable response to cold, but maybe they had some tough time trying to vitality test these teeth. And so they do the 3D image, and what do we see? And it's kind of crazy what a different story it tells in this case. This is one where they actually do see the fracture line. Do you see that fracture line in the tooth? So there's enough separation between those tooth pieces that you see the fracture line. But even if you didn't, you look at the bone around the tooth, and the maxillary sinus border here is completely discontinuous. Bone loss all around the distal surface, and then coronally around the mesial surface of the root. Then you do see a little bit more of a lucency around the apex of the tooth as well. And so kind of crazy the difference. Maybe in hindsight you could go back and say, yeah, where's the lamina dura here? This bone is just gone. But it looks like there's bone here because you still have some buccal and lingual plate. Let's see, here's a case from Boston University. Younger patient, how old is he? Teens maybe. And he had a fracture. You can see on number 9. They wanted to see what else was going on. Panoramic might have looked a lot like this, or it doesn't look much like a root fracture. Maybe you're curious if something might be going on here. And so let's get a 3D view. And oh yeah, what do you think of this tooth now? Multiple fractures all the way through, probably not salvageable. So this adds to our diagnosis, right? Being able to see that. Why didn't we see that in the panoramic reformat? You'd need the x-rays to really shoot right through the same direction as the fracture line to be able to see that. And so you can see how 3D imaging can be complementary to what we see in 2D. Let's see, I don't remember this case. This was just for my private practice. So just a cone beam CT that I received. In most cases, I don't get much of history. So it's just like, here, interpret this cone beam CT. That's mostly what I get. And so I look through this, and I have to look through every tooth and determine what's going on. So I kind of created this reformat to show you maybe there's some PDL space widening here. PDL space widening, I would say, is not a specific finding. I've mentioned that before. Could just be occlusal trauma, especially when they've had a previous endodontic treatment. Is that a healing lesion? Is it apical scarring? And so a lot of that is going to depend on the clinical symptoms and the progression of the lesion. So if symptoms are getting better, obviously that's a good sign. If the lesion is shrinking, obviously that's a good sign, and vice versa. If it's growing and getting worse, it's a bad sign. And so you always have to correlate. But when you look in the 3D view, what didn't we see here? This periodontal bone loss around the distal surface. And if I saw another view, you'd probably see distal furcation involvement on this tooth. But here we're just looking at kind of a sagittal slice, so from the side. And then this looks like a lot of root resorption. And it's kind of crazy how much tooth structure is missing here. If this is caries, maybe it's caries extended to the root because it started here in the cervical aspect. And so there's a lot of tooth structure missing that didn't necessarily show up in the 2-dimensional reformat. And I didn't have actual periapicals, so I was just kind of recreating it with the 3D data. All right, oral surgery. Third molar impaction or other impacted teeth is another indication for CBCT. If you want to see where that root is in relation to the canal, we've done our slob rule, but imagine trying to do that for these impacted teeth. It'd be really tough to tell, really tough to get multiple angles on that impacted third molar. And so that's another case where 3D imaging is a great modality. Is this really close to the canal? Is it buccal or lingual to the canal? You don't know just looking at this pano. And so here we've traced the canal, and you can see in the cross section, this is kind of on the inferior lingual surface. This is a different case, but it just goes across the apices of the tooth. And I would probably want to remove that red dot because you want to see if there's communication through the cortex. If there's communication, there's higher risk of injury, obviously. If it looks like the root really extends into the canal, there's higher risk. And then especially sometimes the roots even curve around the canal. And so there, if you're going to take those roots out, if you just pull them straight out, you're going to sever the nerve itself. So some are really high risk. So oral surgeons are going to look at these and determine, risk versus reward. Sometimes if it's really intimately involved with the canal, they're going to just decornate the tooth if they have to, or leave it. Right? If it's not causing other problems, you can leave these teeth. But if you're worried about resorption or caries on the second molar, you can decornate the tooth. And most cases, patients do pretty well. Of course, there's risk of that getting infected and then still having to go in and get the root. And showing the similar thing here, maybe even the same case, but just showing in axial slices. So this is a horizontal slice. You see the impacted third molars here. Here we see more of the roots. And this is going from, looks like top to bottom. And then in this plane right here, you really see where that canal is closely approximating the root surface here, right near the apex and further inferior. All right, and this is where the oral radiologists specialize, right, in pathology characterization, telling you what a lesion might be. In this case, in this panoramic radiograph, the sinus just looks strange. Maybe I can blow that up. We have our Waters view. Looks like there's some tissue within both sinuses, but this one looks enlarged, and it looks like something is encroaching into the nasal cavity. So it's pushing the mesial border further medially, the medial border. And then this is not a normal sinus border. There's a lot of variation in sinuses, but this just dips too far down in the anterior. It's also very curved, has a very benign type of appearance to it. Here we have an extracted tooth. Was it just something that came from that tooth? And this ended up being a tumor. I don't have in my notes what type of tumor this is. And so a little subtle. I mean, if you look at these borders and say, yeah, that could just be a normal sinus border. Maybe there's a oral antral communication here where they have this molar extracted, and that could be part of the problem. Here's a case I showed you when we were going through anatomy, right? Little review here. Your pterygomaxillary fissure, posterior border of the sinus, zygomatic process of the maxilla. On the left side, your pterygomaxillary fissure, posterior border of the sinus, the zygomatic process of the maxilla, and we have this extra wall here. Is it just a sinus septation? It extends all the way up. It looks like another sinus border. It looks like an extra anatomical structure. And so this was a case where they did a 3D view. Now we have the sagittal slice. And you can see that something is communicating with this socket of the third molar, and it's extending up the posterior border of the sinus, posterior border of the maxilla, and it's kind of causing this separation between the posterior wall and the posterior border of the sinus. Here's just from the coronal view, so you're looking right on the patient. And so this is where the sinus should be. Here's part of the sinus that's still filled with air. Nasal cavity here with the turbinates. Little tiny superior turbinate there. But this is very well defined. It's corticated, it's round, it looks very benign. What do you guys think this is? Based on its location, can tell you. It's communication with that extraction socket. This is just a residual cyst. We said periapical cysts. If it is a true cyst, even if you extract the tooth, even if you do endodontics, that cyst can continue to grow. And this is happening to grow up the posterior maxilla. All right, so just summing up all the indications of CBCT. Big one we said was implant planning. We showed you some endodontics and trauma cases. impacted teeth for oral surgeons, pathology characterization. One thing I like to see with pathology characterization is I like to see both sides. So sometimes they have a lesion, if you suspect just a periapical cyst or something, but once it tends to get large, I like to default toward a large field of view compared to the other side. You saw in one of those cases, that sinus case, one of the big reasons I could tell something was odd was comparing to the sinus of the other side. Even though I have mentioned you can have variation in sinuses quite a bit, but that one just looked strange. And then sometimes I've had pathology and they cut off a lot of the lesion. And I have to say, I don't see how far this extends. Could it go all the way back beyond the maxilla? I don't know, because the field of view is cut off. Periodontology showed you a case where we saw more bone loss that didn't really show up when I did the two-dimensional reconstruct. Trauma, we talked about that. I haven't talked much about TMJ. So if I say cone beam CT is great at looking at bone structures, we have good resolution, you can really well see most osteoarthritic changes, because those have to do with sclerosis of the borders, erosions in the borders, what they call subchondral cysts, little small, well-defined round cyst-like structures, but adjacent to the articular surface. So most of those things you can see within the bone. But what was is that a bird flew into the window? Hi. But one of the drawbacks or limitations of cone beam CT is soft tissue visualization, and you can't actually see the articular disc. Even in medical CT, you can't see the disc. But MRI is the only one that shows the disc. So it does a better job than Pano, other imaging we have. Also airway analysis, that's somewhat controversial, but I will include it for some of my reports when I see that the airway looks constricted. That's obviously not diagnosing sleep apnea in someone, but it is a risk factor. And it's a serious condition that's very common. And so I feel good about commenting on it when I see it, right? I think you could be doing patients a lot of good. And a lot of dentists get into treating airway, and you're not typically diagnosing. Some I've seen, they do send them with an at-home sleep test, but I think they have to have that analyzed then by a sleep doctor if they're not certified in sleep medicine, which is something you can do. That's something you can do, remotely as well. You can send that sleep study into a sleep doctor and they can diagnose it, and then you can treat it. Usually the first line is what for sleep apnea? Kind of the gold standard is the CPAP. And so I believe that takes another doctor to prescribe that. But if they're not tolerant to CPAP, which a lot of patients aren't, what can you do as a dentist? You do an oral appliance, mandibular advancement device, right? And so there's a lot you can get into with as a dentist, and a lot of good you can do for patients that I think is in a lot of cases overlooked. So this is like most guidelines they give you for when to use things. It's kind of similar to if you read through that PDF I gave you for the ADA guidelines on prescribing radiographs. They give you some guidelines, but then ultimately it comes down to using your clinical judgment, right? You're the professional. And so a lot of these guidelines are pretty confusing. These are from like reviews of different guidelines. There's conflict between different guidelines in implant dentistry. That may be an old one, because it seems like there's more and more consensus that it is advisable to use for implant dentistry. But yeah, there is a lot of disagreement between these different guidelines, right? Which is why mostly we ignore them. We're influenced by numerous factors, right? Often poorly presented. These guys were just reviewing all the different guidelines they could find. And this was 10 years ago, so maybe some things have changed by then. But they basically just found a lot of conflicts on when and when not to use. We have this advisory statement from the ADA. This is in 2012. So same year that the guideline on prescribing radiographs came out. All right, and this is going to have some similar wording too. After your health and dental history examination, professional determine the benefits outweigh the risk. That's what it always comes down to, right? Not used for screening. That ADA always says that regarding radiograph prescription. So the same is true for cone beam CT. I do know there's some dentists that don't follow that guideline at all, and they do cone beam CT for everyone that comes in their office. I believe that most radiologists are going to say that's kind of excessive. That's kind of really pushing the limits. You don't need 3D view of every patient to treat them. Some patients are going to be really low carriers risk. They're probably never going to need an implant, right? You can tell from pano that they don't have impacted teeth or other things going on. Additional consideration for children and adolescents, right? They're more at risk of radiation. But when the diagnosis yield will benefit patient care, enhance the patient safety, or improve clinical outcomes. So typically considered adjunct, not your first line of imaging, but adjunct to traditional modality unless you determine structures would not be captured adequately with 2D imaging. So that kind of sums it up. Use the smallest field of view, lowest settings possible to get the desired results. That's why I like our machine here for implant planning. Compared to most cone beam CTs, it is pretty low. Although most companies are coming out with the low dose versions. Prescribed by a dentist with education and training in cone beam imaging, selection, and findings. Evaluated by someone with appropriate training in interpretation. And so I would say, similar to what we talked about with legal, if you don't have that training, it would behoove you to send that to get reports on cone beam CTs. They also mention how the entire data set should be interpreted. Nothing different than what we talked about with pano, with any imaging. You're prescribing it, you're responsible for everything seen in the image. With panoramic, by now there's a lot of anatomy you see in panoramic, a lot to know, a lot to recognize. A lot that I think a lot of dentists don't recognize. I remember when I was a dentist and I realized I didn't know what most of these structures were. And that's only about 10 to 20% of the entire volume, because that's all that's in focus, right? Following that focal trough. Now we're looking at cone beam CT, and in these medium to large field of view, you see all those skull base foramina. You can see lymph nodes when they're swollen, and to some degree, you can see those soft tissue outlines as well as all the osseous structures, right? So should receive training and education, follow state regulations and federal, consult CBCT guidelines. As we just showed, some of those guidelines are really confusing. They kind of conflict each other. They're also, this is my organization, American Academy of Oral and Maxillofacial Radiology. They've come out with some position statements. And basically they say for implants, yes, use it. If I want to summarize what they say, right? They do recommend cross-sectional imaging, meaning 3D imaging and looking at the cross-section of the arch to see where that bone is for assessing all implant sites. And that should be the method of choice. I guess if we compared cone beam CT with medical CT, before cone beam CTs were so popular, there were a lot of surgeons sending it out to a physician to get a medical CT. And so what I've told you is that's on average about 10 times the dose. And so that's more dose than is needed. They do recommend periapical imaging for postoperative assessment, panoramic for excessive, and then CBC for, nice misspelling here, complications. And then there was also combined AAE, the Academy of Endodontics, with AAOMR, to have this joint position statement on endodontics. And in this one, they say, if I sum this one up, not to default to cone beam CT, but like in that case I showed you where they had a periapical radiograph and it wasn't really correlating with what symptoms they saw, with what they expected, then they went to CBCT. Whenever there's any additional factors, like even if it's just strange anatomy, you see really curved roots, you're not sure how many roots are in a molar. So any of these additional factors, rather than just a straightforward case, then they do recommend 3D imaging, right? So anything where the required information is not answered adequately by lower dose conventional radiography. And so that was the recommendation from that, updated in 2015. And so this just kind of summarizes that same thought process for every different scenario. Periapical pathosis, right? Select cases only. In a lot of those cases, you can diagnose with your intraoral radiograph. You see a periapical radiolucency, right? You do the vitality testing, and you can be fairly confident in your diagnosis of a necrotic tooth and the need for root canal. So I'm thinking like, simple premolars, anterior teeth, something without complicated anatomy. All right, they do indicate a high resolution, limited volume CBCT, because when you limit the volume, you can get a higher resolution, you can get a better image. When there's any complicated factors, like I said, previously failed, so that would be a complicating factor. 3D imaging can help determine potentially why a previously failed endodontic treatment failed. And so that's an indication. Perioendo lesions. You know what a perioendo lesion is? It's when you have like a very deep, severe periodontal lesion, and it extends all the way down the root and communicates with the apex. And then the question is, what came first, the chicken or the egg? Was it a periodontal lesion that led to infection of the tooth through the apex, or was it a periapical lesion that then created a fistula along the border of the root? And so those can be complicated. So anything when there's basically complications, they recommend 3D imaging, including, as I've said, root canal anatomy, when there's complicated anatomy, endodontic surgery too. My mom last year got a endodontic surgery. That's one thing I didn't do as a dentist. I never did an apicoectomy. And so my mom thought I was there to comfort her, but I was just sitting there nerding out with the endodontist the whole time, watching him cut out this root, and it went really well. It was cool. But endodontic surgery, that's one where they recommend high resolution CBCT. They do say select cases. So, I guess you can imagine cases where it's pretty straightforward and the endodontist has a fairly good idea of exactly where that root is. This is one where I would kind of lean more toward doing the 3D imaging though. This is a complex thing. I could imagine though, like anterior teeth, incisors, you have a really good idea of where that root ends and where exactly you need to go in. All right, trauma. It's indicated in selected case if you suspect root fracture, if there's luxation or displacement of teeth. Larger field of view if you suspect alveolar fracture. So yeah, summarizing that, anytime the needs outweigh the risk, right? The benefit outweighs the risk. Not considered routine though, and only after thorough medical history, clinical examination. In most cases considered adjunct, right? Unless you see any of these complicating factors, that kind of sums it up. And then similar idea, summing up all those things together. If I just gave you a few bullet points on what to think when using CBCT implants, yes, period, right? I think that one's a pretty straightforward one. A lot of that is influenced by legal cases I've seen. That line of questioning is going to come up if there's any complication with implant, if that patient chooses to sue the dentist. It also is influenced by the fact that we have such low dose. That the question is, why not? You have this CBCT that's maybe the dose of 2 intraoral radiographs, and in that mind, it kind of justifies people, in some cases, defaulting to CBCT, but especially for implant planning. All right, pathology. In a lot of cases, it'll be indicated if there's any question in the diagnosis, if it's going to aid your differential diagnosis. I would say in some cases, they're more straightforward, right? What do you think about if you see an antral pseudocyst in a pano, it looks just like every other antral pseudocyst you've seen. Do you want to send that for pathological analysis? I would say no. Those are so common. That's more of a panoramic 2D diagnosis. You'll see those, be able to recognize those. Hopefully your faculty can recognize those. If not, I can take a look at it and confirm, yeah, it looks like that. That doesn't mean it's a definite diagnosis. It's not going to be 100%, but when you're 99.9% certain, and it's not going to require treatment, probably not going to require a CBCT analysis. I would say in most cases of seminoosseous dysplasia as well, that's going to be more of a 2-dimensional differential diagnosis, which maybe the only thing on your differential because it just looks like it, and you've ruled out a periapical inflammatory lesion. You're just going to say, yeah, that's consistent with periapical seminoosseous dysplasia or focal seminoosseous dysplasia, and in those cases probably not require CBCT imaging. If it's a more severe case of seminoosseous dysplasia though, if it's florid and it's expanding and it's really involving the teeth, you might want to do a CBCT. But yeah, anytime when the traditional imaging is not providing adequate information. This applies for pathology as well as anything else. And this in green sums it up. All right, anything where you need additional information about 3D structures. And that goes along with implant planning. With 2D imaging, you just can't see the direction of the bone, the shape of the bone, the thickness of the bone. To some degree, you can see the height, but even that can be deceiving, right? You can have distortion in radiographs. Now we get to how it works. This is look up the video on the retroencabulator. This guy's describing how it works. That's what I'm going to sound like for the next few minutes. Just completely made up terms. No, we'll talk about how these work a little bit. Don't need to get too much into depth. But X-ray generation is really similar to traditional radiography, but these do have longer exposure times, so they require higher quality X-ray tubes. Some X-ray tubes utilize rotating anodes. Why would you want a rotating anode? And that's going to be more common in MDCT because they require such a higher milliamperage. The drawback of having a small focal spot is the potential to melt the tungsten. It has a high melting point, but if you're using a relatively high MA or a long time, that's going to really heat up the target. And so having a rotating anode, what that does is it spreads that heat around that entire rotating anode while maintaining a small target size. So yeah, a lot more common in medical CT than it is in CBCT, but some CBTs, I believe, do have those rotating anodes. And then similar concepts to what I taught you about KVP, MA, all those things, exposure time. That will be adjusted based on the size you use and some of the other settings. You might choose, some of them call it a high fidelity, high resolution setting, and then it's going to have probably a higher MA or a longer time exposure. Some of them may have higher or lower KVP settings. So this is one where, depending on the settings that you use, it will adjust the KVP and the MA for you. Some of these do a scout exposure. And so you put the patient in the image, you align them, and it does just a quick, really low dose cephalometric projection just to see if you have things in the right field of view. And then you can adjust the patient or you can adjust the machine based on that. But then it also may adjust the KVP and MA to make sure it has an adequate image. And so these charts just show, 60 KVP across the top row and increasing KVP as it goes down. What do you notice about the contrast as we go from 60 to 90 KVP? What did I say about increasing contrast? Or increasing KVP, what it does to contrast? Look at the marrow here, how dark it is. And then it's more kind of a light gray. And these ones, increase in the KVP led to a lower contrast. We said for our intraoral imaging, typically it's around 65 KVP. That's ideal for really distinguishing those structures. But if you have a really large patient, maybe taking a large field of view, more of the adult settings, it might require a higher KVP just to have those penetrating photons to get an adequate image. And then what's the difference with MA? The real difference I notice is noise reduction. Look at the noise just around that condyle, these streaking lines. It's much less here and even less in the 50 MA. All right, and so yeah, your image can adjust those. This is what the raw image looks like. It's going around the patient and it's basically creating these cephalometric projections. This is limited to the maxilla. And this is not a 3D image. It's just putting together these individual cephalometric projections. So all that data has to be reconstructed into an actual 3D data set. If you can imagine that, each of those images is being created within about 20 milliseconds of each other. So it has to have a very fast readout, relatively fast computer system to be able to read that, send that signal to the computer and be ready for the next acquisition. This technology wasn't available until around the 90s. This is early on one of the detector systems they used, image intensifier with CCDs. And that's an older technology now that creates a lot of distortion, noise around the center of the image. Not the best for patient motion. What we said now is most of these use flat panel detectors. That's the most common one used in cone beam CT. This was one of the old machines with the image intensifier. Some of them can have CMOS or even CCD detectors, and they'll be aligned in arrays. That gets pretty expensive because you can't make those sensors large, and so you just have to have multiple sensors next to each other. And so I showed you that initial raw data, which is just like hundreds of cephalometric projections around the patient. So that's connected. It initially just gets kind of cleaned up. So the offset is corrected. Some of these dead pixels you see, well, I guess that doesn't happen until the last step here. But different calibrations it does, it goes through the machine, and that's all done right in the acquisition stage. And then that's sent to the computer for reconstruction. What it's showing here is taking just kind of one row of pixels from each of those cephalometric images and lining those up next to each other, and that creates a sinogram. And that's going to create similar data to what's collected in a medical CT. Remember medical CT, it's almost like it's taking just these axial rows as it's going around the patient. I was going to say one at a time, but like 64 at a time. And so that gets the same data as they would get in a medical CT. This is showing the cone beam CT data as it's fed into there. You create the sinogram. And then this is showing a medical CT. It's automatically just taken more as axial slices. And then that's fed into some reconstruction algorithm. And that takes time. It's very computational, intense. In fact, we didn't have computers until the late 90s, even capable of doing this in a time that would be reasonable for us. It should be less than 5 minutes, right? We want it relatively quickly to be able to see if that image is good and usable. And so reconstructing that, this is the classic algorithm they use, it's called the Feldkamp method. It does create some distortion. There is a lot of research into different algorithms, or maybe using different geometries. Because one limitation of using that cone beam geometry, you're only going once around the patient. And I've shown you that metal scatter or any dense material artifact, it scatters off in the axial plane. That's because that's the direction that the image is going around the patient. And so if you can imagine something completely dense, some metal crown or metal restoration, it makes it really tough to get data around that crown in the axial plane. And so they could potentially do, helical orbits around the patient or orthogonal circles, not just going in one same plane around the patient. And that would help clean up some of that, some of those artifacts. But other algorithms may just be better at constructing that 3D data from the same acquisition data. So there's a lot of research going on into that. Interesting things. Talk a little bit about the display. My home setup doesn't quite look this nice. Maybe I'll get there. But I mentioned a good thing about ours is we can change the field of view. We can change the orientation. We can change that on the fly. Kind of the typical radiology view is multiplanar reformat, this MPR. That's where you see the axial plane, coronal plane, and sagittal plane. And then usually you have 4 different boxes, the axial, coronal, sagittal. Each one shows you a single plane, and then one will show you a volumetric one. Kind of like this is a volumetric representation of a person. And you have little indicators, these lines, which indicate what plane you're viewing in those other planes. So this is an axial slice through the mandible. And the sagittal slice, it would show you here in red. The coronal slice would be here in green. And so if you scroll through the coronal slice, you'll see this line moving. You can also see it in the 3D reconstruct. Just like with any software, you can zoom, you can change the contrast and brightness, you can annotate, and you can measure. And so here's a video of me going through my cone beam. Axial slice up here, so like a horizontal one, sagittal from the side, and then from the front is coronal. You saw me move, kind of drag around the 3D image. Here now I'm changing the orientation so it aligns with the right side of the arch. If I wanted a better look at those teeth. And then a little bit I was zooming in and out, so kind of going buccal and lingually. Now I'm changing the contrast, brightness. And I think I do a little bit of measurement here at the end. All right, you can measure in any direction. As long as you're measuring in the direction you want to go, it's going to be accurate. You know, within less than 0.5 millimeter, they've shown there's accuracy in measurements. All right, so I think that's it for the software. Showing that you can change the orientation, create oblique planes, align it however you want. I mentioned how if the patient is rotated or off center, you can just change that just like I showed you there. When I'm viewing teeth, I don't typically do this. Align some oblique plane to the right side. Typically when I'm viewing teeth, I'm looking in more of a curve, like a panoramic curve plane, so I can see all the teeth at once. Panoramic reconstruction. What do you notice about this panoramic? What do you notice about the ghost images? For the most part, they're missing. Where's the ghost image of the opposing mandible? Because now I'm limiting everything I'm seeing just to that area around the jaws, just to what would be the focal trough in a panoramic radiograph. So there's no ghost image of the mandible, no ghost image of the spine, the hyoid bone. It's just limited to around the dentition. So that is an advantage. I would say these are roughly similar quality to a panoramic image with some advantages. Maybe panoramic has a little bit higher resolution in some cases. I see a little bit of ghost image of the hard palate. All right, and then we have what's called the arch section, or a section that follows the curve around the jaws. This one looks kind of more like a thicker rather than a single slice, so it looks more like a panoramic image here. But this is showing you, the intent to do implant measurements. So you create this arch section. This orange line represents dots that you can create or you can adjust around the teeth. And then these white lines are cross-sectional images to that arch. And so now we can see in this cross-sectional image, which is probably right here in the center of this implant site, they do a measurement, and they measure what, 22.5 millimeters of bone. That's more than enough. You can sink as long an implant as you want in there. But what do you notice about this? If you haven't changed that orientation to align with the direction of the implant, you're measuring diagonally, and that's going to give you a longer measurement. Even though this measurement is accurate, that measurement is diagonal along the cross section, and so that gives you artificially increased bone height. And so you have to reorient that volume so that you're measuring the same direction that implant's going to go, and then that'll give you more accurate. See how different that is? 7.5 millimeters less than what we thought when we measured diagonally. So you have to make sure you're measuring in the same direction that the implant's going. You can also look at the bone width, right? This one's pretty uniform across there, but sometimes there's more of an indentation. You can have some areas where it's really narrow, so you got to pay attention to that. And here's a mandibular site. Again, your arch just follows the curve of the teeth. You want this oriented where up and down follows the direction of the implant. And then you can see the shape of bone, the height of bone, the width of bone. This one's somewhat S-curved, but it looks like there's a good volume of bone here, right? Probably adequate for implant support. The inferior alveolar canal is way down there. That's probably like almost 30 millimeters to the top of the alveolar bone. And then again, we have the nerve traced. We have this directed in the same direction the implant's going, multiple cross-sectional views. Then we have measurements. Sometimes you'll see that, based on the direction you need that implant to go into occlusion with the opposing teeth, there may be a buccal defect. It may look like there's plenty of bone, but it slants toward the lingual. And so you got to measure to where you want that neck of the implant to be. So a lot of variation you can have. All right, here's just a quick introduction to looking at the TMJ. You've got these which are somewhat coronal views, like you're looking at the patient, but see how This is oriented to the poles of the condyles. The condyles go like this. And so you want that coronal view to basically follow the medial to the lateral pole of the condyle. And then the cross-sectional view is going to be at 90 degrees to that. And this is a great view for looking at them. You see a little bit of a concavity here. There's a little bit of an erosion lesion. So that's one of the signs of osteoarthritis, potentially leading to patient symptoms. You look for osteophytes, which is kind of sclerotic bone formation on the surfaces, on the articular surfaces of bone. And this is a really common place to see it, is on the anterior of the condyle. And so a couple different signs of osteoarthritis. This one shows probably a little sclerosis and osteophyte formation. A little bit of flattening, maybe a sign, but to some degree there's physiological remodeling of bone around joint spaces. But what I don't see is the disc itself. I do see that there's healthy space between the condyle and the articular eminence. And if I see that there's reduced space, or especially if there's bone-on-bone contact, I know there's not a healthy disc in there. So in this case, I don't see the disc, but I don't see evidence that there's not space for the disc at least. 3D rendering, this is what is really demanding on your computer system. And this is why you probably do need a dedicated graphics card, like you need a gaming computer to run cone beam images well. But I don't spend a lot of time looking at the volume rendering because I'm looking through the slices, and that what I've found is usually requires more RAM, like to look slice to slice to slice as it's scrolling through. And so I find it really RAM dependent rather than, but if I'm looking at this and manipulating the 3D image, then it's really the video card dependent. All right, so this is your typical one. It's called ray sum, which is basically creating a cephalometric projection. It's summing up all the voxel values. I haven't talked about voxel yet, but all of those points throughout the volume in one direction. And of course, you can change the alignment. So this is kind of recreating a PA ceph, but you can change the orientation. You can make it look like a lateral ceph or anywhere in between. So ray sum, or you could call it ray averaging, because whether you sum it or average it over that, it's going to kind of give you the same result, which is kind of the average gray value of all the voxels, all the different points through that line extending through there. And compare that with MIP, maximal intensity projection, where that instead of giving you the sum or average, it gives you the maximum. And what that does is it makes dense objects really stand out. You can see this patient has a lot of surgical clips, and those really stand out. Metal really stands out. The ray sum is the more common one. Then you have volumetric transparent. I showed you that one. And shaded surface display. This kind of calculates bone surfaces based on differences in contrast. And to some degree, it can determine that, yeah, this is a bone surface. Then it makes it look like there's reflections coming off those bones when seen at different angles. This one is more just assigning yellow or orange once it gets to a certain threshold of gray level. And so that makes the bone stand out. But this one with the reflections really gives it a 3D view. All right, so which one was this? It looks like just a typical cephalometric. That was our ray sum. If these metal screws stood out a lot more, it would be your maximum intensity. But just your very similar to a cephalometric is ray sum. All right, image enhancement, it looks like we increased the brightness and contrast a little bit. And then this one, it looks like they did a little edge enhancement to really make those trabeculae stand out. Small lines are going to stand out more, but it does create, just like with our 2D imaging, when you do that image enhancement or edge enhancement, it can create some artificial dark lines. So I would say be careful about this. Yeah, I can make certain things stand out better. Makes it appear more detailed. But if you do it too much, you're creating artificial kind of artifact lines, dark lines around it. All right, resolution. You all know what I mean by resolution. We've talked about resolution. Traditionally, it's done with line pair phantoms, and we talked about that. The more line pairs per millimeter, the higher detailed structures you can see. These are alternating light and dark lines. With this one, maybe you see a little subtle difference at the 12 line pair per millimeter. And so it's just a subjective measure of the resolution capacity of this imaging system. We do similar thing with 3D imaging. Then they've got these little plates of alternating light and dark lines. And instead of just having a subjective, some person look at it and say, here's where I see separation between the lines and here I don't, they do this modulation transfer function is as small as they can go and still maintain a 10% difference between the light and dark lines. And so that's more an objective measurement of resolution. You can do that with digital imaging. They do that with 3D imaging. And so they did that in a study here over 10 years ago. These are contrast resolution phantoms, and then these are spatial resolution phantoms. See how there's little small, varying cylinders that contrast slightly? And then these are those alternating light and dark lines. Of these ones, which looks best? Well, let's compare the bottom row here. Do you think that shows the best resolution? I think all the way down here you can see it, and most of these other ones you start to lose it. And a lot of that is the contrast resolution. This was good at showing contrast and so it would help show little small subtle differences in spatial resolution. But what they found is the highest that they got was about 4 line pair per millimeter, and that was with this machine. So everyone was excited about that machine earlier on. Some of these have likely caught up since then. But if 4 line pair per millimeter was the highest resolution we could get, remember this A over 2B formula? Converting from either resolution to line pair per millimeter or back, or either way, it's the same formula. And so that means that 1 over 2b, if it was 4, 1 over 8 is 0.125 was the highest resolution you could possibly see, which is not bad. I mean, it's good comparing to other modalities, specifically medical CT, but not nearly as high as intraoral radiography. Panoramic, the highest they got was about 5 line pair per millimeter. That's why I say these are pretty similar in resolution, panoramic and CBCT. And those high resolution ones, it's really good at looking at different things. Here we see resorption in a root canal. If I'm doing root canal, I want one of these high resolution ones. But in most cases, that's still not enough to see a root fracture, as I've said before. So voxel, which I've talked about, that's just a 3D representation of a pixel, right? Instead of a 2-dimensional image, you have a 3D volume. And that's broken up in the computer software memory into these small voxels. So kind of think of it as a smaller block that makes up a 3D image. And there's no way to look at every voxel at once. That's why you're looking at slice to slice. If I look at one of those 3D renderings, I'm kind of just looking on the surface for the most part. You can't see through it unless you scroll through slice to slice, and I do that in the different directions. But there is that data there. So you just think of this as this data set that represents these different blocks of information by different grade levels. And so the smaller the voxel size, the more detail you're going to be able to see. But then don't confuse voxel size with actual resolution, because resolution depends on a number of things. So a lot of salesmen will try to sell you on, oh, this machine is 0.08 or 0.05 millimeter resolution, because that's its capability of storing voxel size. And to some degree of the sensor, right? The sensor has to be high enough resolution to capture that voxel size, but usually it's limited more by other things. So it can be limited by contrast resolution, reconstruction techniques, focal spot size. So that's an interesting thing. With intraoral radiography, the sensor is close to the object compared to where the tube head is. But with cone beam CT, the object is in a lot of cases almost halfway in between. And so if you remember the effect of focal spot size and distance between the object and the receptor, if the object is closer to halfway in between the X-ray source and the sensor, then that focal spot is going to have a lot more difference, a lot more impact on your resolution. If you go back to that drawing exercise I had you do. And so if some machine has a 0.5 millimeter focal spot size and they're claiming, sub 0.1 millimeter vox or resolution, that's probably not going to be accurate because it's going to be limited. There's also noise that distorts it, that affects the resolution. And then to really get the high resolution, to reduce that noise, you can increase the MAS. But for the most part, cone beam CTs are not going to have a really high MA. And so not going to give you that opportunity to really increase the MAS, but we don't want to anyway. So resolution, I've talked about this one before. Bit depth, right? The number of bits dedicated to an image, and that'll determine the number of gray levels, and it's 2 to the n. And so most cone beam systems, this is potentially not a limiting factor because they go up to like 16 bit depth. But then as that image is exported and sent, they do kind of dumb down the data, and they may only export it as 12 bits. And so to some degree, we're not getting as high of a resolution as we could, as contrast resolution. All right, I was just talking about focal spot size with that. Also noise from images. So this is changing the MAS. We see kind of this noisy images, and kind of this granular appearance. That's from noise, and that limits our resolution to some degree. Here we've reduced the noise by just increasing the MA. So 5 times the MA, that's going to be 5 times the dose to the patient, but it does help give a lot clearer, crisper picture by eliminating that noise. Field of view can affect it quite a bit. If you want to be looking at TMJs as well as the airway and everything at once, probably want one of these larger field of views. And so that'll allow you to see the TMJs, the airway, but gives you less detailed imaging of any one structure. So the teeth aren't going to be quite as high resolution. To really get the high resolution of the teeth, you want one of these smaller field of views and just focus on the teeth in question. That's for if you're looking at fractures, endodontics. Talk a bit about noise here. Biggest one, I think, is patient motion, because that's controllable. That's something we can do to reduce it. For a cone beam CT, you really should have your operator, your technician or assistant, whoever it is, have the ability to watch someone and see if they're moving during the screen. Sometimes that's a mirror or looking through a window, but that can help a lot. But you can tell if a patient has moved just by looking at the image. We'll talk about all these artifacts though. This is movement artifact. Looks like a double layer. It was going around, I imagine this is going around one side of the patient's sitting in one spot, but then they move a little bit. And then as it gets to the other side, they're in a different spot, and it creates this kind of double image, double contours. And you can see where just the mandible moves and the rest looks pretty stable. You can see where kind of the spine has moved. But if they move the entire head, then obviously everything is going to show that double contour. And this was a case where it looks like a fracture, but it was just a case of patient movement. Like what I was talking about, where the patient's in one location and they kind of move forward or back as it gets to the other side. And it reconstructs the data best it can, but then it ends up creating this misalignment of the anterior mandible. This was a similar case, interesting because it looks like the buccal cortex is aligned, but the lingual isn't. But if they shifted up or down, you can imagine that happening. Maybe there's some discrepancy in the width of the bone on the lingual surface here, but they tended to align on the buccal surface. So both these are other descriptions of, or examples of patient movement. In most cases, though, it looks like this, where it's more of a double contour. So do everything you can to stabilize the patient. This is what we want to avoid. Some patients, it can be difficult. This is similar to our ICAT, just a chin rest, and then there's also a head rest that maybe you don't see there. And then varying degrees of patient stabilization, where it starts to almost look medieval. But yeah, really stress to the patient that they need to be able to hold still the entire time, because that's the biggest one that you can't undo that. And if it's bad enough you don't see what you can see, don't see what you need to see, then you're going to have to retake it. So this is a ring artifact, just like it sounds. A ring around the, kind of around the center of the image in the axial dimension. And that has to do with just pixels on the sensor being out of calibration. So it's not calibrated with the rest of the machine, and it creates this either light or dark line all around the center, so or the center of the image. So all 360 or whatever images as it's creating, that pixel has that same off value. This is a different one. Looks a little bit different than that last one, but you can see it does radiate from the center of rotation of the volume. And so that one can be fixed as well. That just requires calibration. If you see this, call your vendor or whoever's maintaining your equipment for you, and they can recalibrate that and get rid of that. So you see that to time. Quantum noise or scatter. Noise is just, as we said, noise happens from scattered radiation. And you can overcome that by increasing the dose, basically, increasing the MAS. Or in some cases, it's the same idea, but machines that only go 180 degrees around the patient, usually if you do a full circle around the patient, it increases the time of exposure. And so time or MAS, that's what's going to pay off to decrease your quantum noise. You have a higher signal to noise ratio, then your noise kind of goes away. And then this is really similar to noise artifact. They call it undersampling. And so if you have not enough image data, it creates these striating lines. Now they're radiating from the center. And that's more thought of as too few of projections as it goes around the patient, right? Maybe you only have a couple hundred projections when you could go to more, because then the software has a tough time putting those projections together, and it creates these light and dark lines that are striating from the center. But really similar idea to noise, that if you increase that number of projections, or if you increase the time or MAS, this is going to go away. So I think of those two as really similar. And so this is interesting. Let's focus on the columns right now, number of basis image projections. So say we go from 180 projections to 360. When you only had 180 projections, the algorithm had a tough time kind of putting all those together. It didn't have enough data, kind of a lack of data here. But when you doubled that number of images, it's like doubling your MAS. And so it reduces that noise, or in this case, moire artifact. Let's look at what they're talking about with field of view. Maybe we can just focus on this higher projection image, this better quality image on the right. So going from the top right to the lower right. And what do we see? You guys notice a difference here? What's really increased? Is it brightness or contrast? Yeah, the contrast is better. And so what they've done is limited to the field of view to just several centimeters around the teeth. Why does that improve our contrast? So think of that geometry image I showed you with the cone, the scattered radiation. You limit that field of view, you have less scattered radiation, and scattered radiation creates noise, which noise is one of the big contributors to reducing our contrast of the image. So that's an interesting thing. Similar concept of going from round to rectangular collimation. You're collimating the image, you get less noise. Ideally, you should have a less noisy image. That could help you with the contrast. This is a artifact known as partial volume averaging. If you're trying to image structures that are smaller than the pixel size on your sensor, then they're just going to be blended across different pixels of the sensor, right? This pixel can't measure a circle. It can just measure a level of gray. And so that kind of grays out the small structure. Basically think of it as pixelization of an image, right? If your pixels aren't small enough to image whatever it is, you're going to get pixelization. And so here's some examples of that. The actual size of the sphere, whatever it is you're imaging, and then it getting pixelized because it's spreading across different surfaces. And so they talk about partial volume averaging when you can't see the borders of the sinus because they're so thin. They get really thin around the roots of teeth. And you'll see that in intraoral imaging as well. Sometimes it looks like they communicate with the sinus, but if you don't see an actual lesion there, it's likely the sinus border is intact. It's just too small to be resolved by the imaging technology we have. All right, more examples of that. Cupping. So these are dense material artifacts, metal artifacts. And basically, if you can recognize that these are metal artifacts, then that's all you really need to know, right? You need to know the technical details behind it. There's different types. Cupping artifact makes it look like that material, radiopaque material, extends beyond its actual border. It kind of cups outward. Scatter artifact, which I think they kind of have this wrong, because scatter artifact, it's scattered radiation. That should be the dark lines. And then beam hardening, what is the hardness of a beam? Now, hardness is kind of the KVP, like the average KVP. The more it penetrates through a patient, the more the low energy photons get resorbed. Remember that? As any X-ray beam goes through any material, low energy X-rays or photons, they get resorbed first. And so the more and more it goes through material, the higher the average energy of that beam is. Higher energy beam tends to penetrate more. And so if it's penetrating more through the rest of the structures in a patient, that's going to be interpreted as a darker area, a more hypodense region. So that's what beam hardening is. But yeah, I would say just recognize that these light and dark streaking artifacts, I would call these streaks rather than the scatter. Streaking artifact, maybe photon starvation artifact is where you get these white lines. Just recognize that they're dense material artifacts. So it especially happens with metal, but you'll see them, I mentioned around, well, titanium's metal. It's just a lower density metal than amalgam or some of these crowns we have. So metal, or even gutta percha, to some degree composite, and to a lower degree even enamel can create some of these artifacts. But it's really only going to streak like this with metal. And so these show some different types of metal, titanium versus lead, and then seen like in cylinders, like implants inside some of these machines, and how they look. You see lead is even denser than titanium, so it creates even more artifact. But titanium, see how in all of these, even with the titanium one, there's these hypodense lines, these beam hardening lines between the two implants. And so that really interferes with diagnosing bone between two implants that are adjacent to each other. Even if they're somewhat far apart, you get that beam hardening artifact that just obscures the bone. Another reason why I say that 3D imaging and 2D imaging is really complementary, because 2D imaging, you can see that interproximal bone fairly well, but you're not seeing the buccal and lingual bone. And then the inverse is true for 3D imaging. Now I can see the buccal and lingual bone a little bit better. There's still probably get some artifacts in some cases around the implants, but I can see that buccal and lingual bone, even though because of that artifact between implants, I can't see the inter-implant bone. All right, we've talked basically, I think, about these points when I did your legal lecture. You're responsible for everything found in a CBCT. That means if you guys are going to be using these, do get more education. Reach out to someone like me, reach out to a radiologist in your area, someone that can interpret. I would say just don't ignore. I think that's way too common, just to be happy with ignoring anything outside of the field of view, and things that could potentially affect the patient's health. This is a little pet peeve of mine. Number 4 here. I see implant planning courses, and one of their bullet points, their learning objectives, is learn to interpret cone beams. And I think, okay, yeah, they're going to have a radiologist or a pathologist talk through how to interpret cone beams, how to analyze the whole image. But no, all they're really doing is showing how to measure bone in a cone beam. And that's not interpretation. And I've noticed a change in our radiology texts. The latest versions of our radiology texts do a better job of going through that. You can go through a whole chapter in our book on cone beam CT anatomy, become familiar with it. One thing I also recommend is looking at just medical CT books, medical CT anatomy. If you can recognize that anatomy, it's going to be really similar on cone beam CT, but actually we see a bit less on cone beam CT. In medical CT, they can actually see the white and dark matter or gray matter differentiation in the brain, which we don't see. But most of that still applies to us. And this is just showing, we've got our single image when we're looking at a pano, but still it would take some time to go through and analyze these. You need to think about what structures you're looking at. and make sure there's nothing abnormal outside of the field of view. And I always do that first, and then I go back and look at the dentition. Same is true when I'm interpreting a cone beam CT. But instead of looking at one single image, as I said, you can't see every voxel looking at any one image in a cone beam CT. So one of my rules of thumb is think of it like a movie rather than a snapshot. You've got to be scrolling back and forth through these different slices. As you can see, there's hundreds of individual axial slices. And there's some things I like to look at more in the coronal view or the sagittal view. And so you've got to scroll through all, several hundred of these, however many they happen to be. And there should be a systematic approach. I'm going to get a little bit into interpretation, but probably don't want to go too long today. I don't have that many more slides on this. And so just like we started with radiology, identifying anatomy, I think, is the baseline. It's kind of the foundation of interpretation. And so if you can identify all the anatomy and no normal variations, because then you don't have to, if you can identify anatomy well, you could potentially at least be able to identify when things are abnormal and then get a different opinion. If you know a lot of the normal variations, then things that you used to think were abnormal start to make more sense to you. And then you can really just refer out times when you see something that's more abnormal, right? And then if you do see pathology just a cult, meaning it's discovered incidentally or incidental pathology. That's pretty rare, but it can happen. This is a good key here. What I see all the time is tunnel vision. I even see this with endodontists or dentists taking a small field of view that only shows a few teeth, but they're only looking at the one teeth where the patient had symptoms. And so, for example, I see like a tooth 13. They take this radiograph on 13, and 14 or 15 has an endodontic lesion in the cone beam CT. But you don't see that if you're not looking through the slices and looking at every part of it. And so it's kind of unfortunate. I see so much that's missed. And I also want to publish some research on some of the things I've seen. And so it is kind of recommended just to look through one section at a time, so you can divide that horizontally into thirds or into quarters, and then scroll all the way through just looking at that, because it's tough to take in an entire image all at once. But if I just look at this top third and then I'm scrolling back and forth, little subtle differences in symmetry are going to stand out to me. And then I go through again, looking in the middle slice and then in the bottom slice. And I'll do that in the axial and a lot of times in the coronal. This is one thing I like using the coronal slices for. All sinuses should drain into the nasal cavity, right? There's drainage. And here we see these maxillary sinus ostia and the drainage really well. And so that's one thing you look at just for analyzing sinuses. And then I do use the curved slices, I mentioned before, to view dental regions. And I spend a bulk of my time looking at the teeth in most patients because dental disease is so common. That's the most common by far thing that I see, is just previously undiscovered periapical lesions of the pathology that I see. Maybe one of the other common things I see is in older patients, you see arterial calcifications. That's a health risk, right? That's a cardiovascular risk, so they should be informed. They should have a consult unless they're already being treated for cardiovascular risks. Multiplanary format to look at the hold volume. We just showed you dividing into thirds. If not sure, look through different slices. Like maybe something makes more sense in the axial slice as compared to the coronal, or vice versa. Avoid just focusing on one area, right? Don't get pigeonholed, don't get hyper-focused. I do get hyper-focused, but don't let that distract you from other things that are going around it. Experience obviously helps. Studying anatomy, as I said, is the baseline. This is where I learned a lot, was comparing to other radiographs. This is why it was advantageous, I think, early on to be able to work at a school where, and I can do the same thing here. If I see something that doesn't make sense, and I think maybe the panel will show that better, I can look up the patient's panel and compare that. And really early on, that was helpful for helping me learn what I look at, what I'm seeing. I guess one example of that is hypersymatosis looks kind of strange in cone beam CT. It's tough to see PDL spaces in individual slices in a cone beam CT in a lot of cases. And then hypersegmentosis almost looked like it just kind of blends with the surrounding bone around it. And so I've looked at that and compared to intraoral or pano, and then it's obvious, like, oh yeah, that's hypersegmentosis. And so things like that. And early on, I used a checklist. Now I have the checklist just kind of memorized in my head of what I go through, and I have it broken out into 4 different anatomical structures. That's the oral structure, the oral cavity, which I said I spend a bulk of my time on. Paranasal includes maxillary sinuses, ethmoid air cells, the sphenoid sinuses, and all their drainage pathways. The skull base is another one, the base of the skull, if you can see the foramina, the orbits, into the cranium. Obviously, you have to look as up high, as far high as it goes. And then the last one is the neck. And I include the TMJs in that because there's typically not as much to report on, although, as I mentioned, arterial calcifications, you'll see that in the neck. You can also see it in the skull as well. You can see intracranial carotid artery calcification, but the common one is the cervical carotid artery calcification. And so, yeah, and then I have in my mind a certain amount of anatomy I'm looking at in each of these categories and things that I'm going to comment on if I see. Right, benefits of checklist in the aeronautical industry and in flight, they've been using those forever. In medicine, they started using those. When did that become popular? 60s, 70s? And they've shown that it avoids biases and shortcuts and reduces errors. And so here's some examples of that. Why you need to know anatomy, first of all, you've got to look at these canals, just to point out a couple here. This is the foramen ovale, the spinosum. This is the carotid canal that's coming in. This is part of the jugular foramen. And then there's this extra thing right here that doesn't really belong. And this was some lesion in the skull base. I want to say it's I wanted to say it was a multiple myeloma, and that's what this turned out to be. It could be a number of things, right? But this was a skull-based tumor that if you're not familiar with the anatomy, it would really blend in with everything else around it. You might look at this and say it's somewhat detailed, but I mean, compared to the anatomy that I could start listing if I looked through a medical CT book, this is pretty narrowed down. And I try to create things as like checklists and stuff for radiologists that start working for me. And when someone starts working for me, I probably spend way too much time. In fact, I've scared off a lot of radiologists. I guess that's a good thing because then I only keep the highest quality ones that are willing to do very detailed reports. But I'll look through them and I'll look through all these things and say, hey, you missed this, and this, and this. But there is a lot of stuff you can look at and a lot of stuff that can benefit the patient. So there were all these periapical lesions that weren't being addressed. I just happened to review 60 patients because they had repeat imaging. And if it was within 6 months, I tell them not to send it to me again. I'll just review and compare and see if there's anything new. And in these 60 patients, 12 of them had undiscovered periapical pathology, kind of a surprisingly high number. And as I went back and reviewed them, in a lot of cases, it was 6 months or almost a year later, and nobody looked at my report, nobody done anything about it. So look through those, and if you see some dental finding especially, but if you see that I've seen arterial calcifications, you should be able to have a conversation with the patient and say, hey, our radiologist saw this. It's a cardiovascular risk factor. Just tell your doctor. At Boston University, we used to send them a letter. And maybe that's a little overboard, but the letter at least would have a description and they could take that to their doctor. But they need to know, hey, there's arterial calcifications, so calcifications in my artery. That's a risk factor, and their physician should know what to do about that. You could print out the report, and that'll be more detailed about where I see the calcifications, maybe how dense those calcifications are. These will also include images. This is where I probably go overboard too, way too many images. Now, let's see, it looks like I wasn't doing it here in this example report. Now I always start with a panoramic reconstruct. All right, in our radiology text, it talks about different sections of a radiology report. The first top part, I have referring doctor, right, patient information, the imaging procedure, and I can get that from the scan. And so I just kind of take that from the scan, what the volume dimensions are, what the resolution is, or at least the voxel size is. And if they do provide me any information, I will include that there. And then I have findings, and this is where I sort it out by anatomical structures. Have your oral cavity, your skull, your neck, and what I leave out: skull base, paranasal location. All right, and then that's where I do more thorough description of anything I see. And then at the bottom, the last section is impressions and recommendations, and that's the section that I'm copying into Axiom now. Any clinically important or potentially clinically relevant findings, including things that need to be looked at by a physician or things that might need to be treated by you, like I see a periapical lesion. If I suspect pathology, I'll provide a differential diagnosis and a recommended course of action. This is maybe a more recent one where I have the panoramic reformat. Sometimes we do a limited field of view, so it looks pretty narrow. This one cuts off the TMJs, but it does capture all of the dentition and the maxillary mandibular bone around the teeth. All right, long enough lecture. Ready for break now. So log in to Pull Everywhere. What was an advantage of medical CT over cone beam CT? And yeah, the higher contrast resolution was the big one. We said cone beam CT is as high or better spatial resolution, but that additional noise, as well as the lower MA, significantly lower MA, is what gives medical CT a better contrast resolution. All right, I didn't go much into interpretation, but would you guys be able to tell this? What do you think of this? Is this a maxillary slice or mandibular? It's maxillary. You're looking at cross section of, this is the mesiobuccal root of a molar, of a first molar. This is a second premolar. This is a first premolar, which in most cases, first premolars are going to have 2 roots. Second has 1. And then these are the 2 molars. So that's a maxillary one. Is it an axial slice? Yeah. But this one, in comparing cone beam CT to medical CT, why does fan-shaped beam lead to better soft tissue contrast than cone-shaped beam? A is correct. Yeah, with less scatter radiation reaching the detector with a fan-shaped beam. What is a major disadvantage of cone beam CT compared to panoramic imaging, which I referred to as the Achilles heel of CBCT? Yeah, artifacts is what I said. We said compared to panoramic, CBCT is roughly the same resolution. And these are disadvantages of panoramic. Using average dose numbers I gave you about how many CBCTs would have to be taken to equate to a year of average background radiation dose in the US. What was the number for one CBCT? It was 100. So yeah, 3 would be 300. Yeah, 30 is correct. So a root canal needs to be retreated. With current periapical images, it's unclear what caused the previous root canal to fail. Is a cone beam CT indicated? Yeah, yes. We said not as a rule of thumb for endo, not like first line for every endo case, but when there's any complications, including we talked about root canal needing retreat when you're not unclear what's caused it to fail, that's an indication. All righty, these, okay, what's the slice basically I'm asking here? A CT image showing a bone window, so it's optimized for viewing bone. What slice? What do you think? Yeah, this is an axial slice. That's the mandible we're viewing through. All right, each of the following but one is a common indication for CBCT imaging, which is not the indication. Looks like answers are in for this one. What is not an indication for CBCT? 100%. Yeah, caries diagnosis, we said, not the best for CBCT. That doesn't mean you ignore the crowns of teeth and don't look for caries. There have been cases where I've seen caries in CBCTs that didn't show up in other places because they're buccal or lingual. Pretty easy one here, maybe. Yeah, all of the above is correct. Accurate description is important. All of these are important. differential diagnosis, recommended course of action. While I'm thinking of this, I mentioned how years ago, I don't know if it's still true, but misdiagnosis was one of the common or the most common lawsuit brought against dentists. And part of that is not providing a differential diagnosis. It's a little tough because I teach you, when you know something's cemento-osseous dysplasia, you know it's cemento-osseous dysplasia. But then if you're wrong about that, if you haven't given a differential diagnosis, that could come back and bite you. And so from my mind, I worry about that when it is more of a usually different type of pathology that I'm not so sure about. So if something's in ameloblastoma, you don't know if it's OKC, dentigerous cyst. We've been through those a couple of times. And so that's why it is good to include a differential diagnosis. Whenever, especially you see something like that, it could be a number of things. That's it. So you guys have any questions? And other than that, I will see you guys tomorrow.